Hello there, Dr. Sullivan here, Chronic Pain GP, and today's brief video is about a group of drugs we use to treat chronic inflammatory pain. So we now know that acute pain is often due to inflammation, for example after an ankle sprain or a knee sprain, but what we do know is that inflammatory pain and the processes which cause the inflammation and pain can cause tissue damage. Now, common causes of chronic inflammatory pain include conditions such as rheumatoid arthritis, osteoarthritis, gout, and SLE, systemic lupus erythematosus. So how do patients describe the inflammatory pain that they are experiencing? Well, often they can use words such as dull, aching, but one of the most common expressions I hear is that the pain is a hot type of pain. So this burning or hot type of pain is extremely common in conditions such as rheumatoid arthritis, and often there is a swelling of the affected joints and reduced function, for example, gripping with rheumatoid arthritis of the hands and fingers. So once inflammation is detected, whether that's due to trauma, injury, or an autoimmune cause, such as rheumatoid arthritis, the body releases its endogenous chemicals to help fight the inflammation. And this is often associated with increased blood flow to the joint or area, and inflammation, swelling, and pain. You can often get leaking of interstitial fluid around the inflamed area, and this fluid, by its nature, is quite irritant, so therefore often patients can have painful swellings around the joints. As well as this, due to the endogenous chemical release, patients can often feel systemically unwell in themselves and can often present with tiredness, lethargy, fevers, chills, and rigor. Associated with this is often the surrounding muscle is often inflamed and can often present with stiffness. Now, if this inflammation goes unchecked long term, often it can present with pain and swelling around the joint capsule, and often this is called synovial swelling. And sometimes, if the inflammation is very long term, it can cause irretrievable damage of the joint. Now, as you can probably guess from my previous videos, the treatment for this type of chronic inflammatory pain is multimodal and multidisciplinary. Specifically for inflammatory type pains, we have a group of drugs called non-steroidal anti-inflammatory medication, or shortened to NSAIDs. Now, NSAIDs work by reducing prostaglandins by working on a specific enzyme in the body called cyclooxygenase, shortened to COX, or COX enzyme. So the non-steroidals have been around for many years and can be administered in different ways, including intramuscular injections through the veins, also known as IV or intravenous, as well as oral and topical creams, where you can rub these creams onto the affected muscles and joints. Now, the current research suggests that approximately 60% of patients who try these medications should respond to them. Now, occasionally, if patients don't respond, often it's worth changing to an alternative NSAID, and this again should improve efficacy. And it's now also thought that it may take 1 to 2 weeks for the full effects of the NSAIDs to kick in. So I put together a table of some of the commonly used NSAIDs. This is not an exhaustive list, and often if you go online you can find a complete list of them, and they include those available over the counter, commonly ibuprofen, aspirin, and some people now consider paracetamol to be a mild anti-inflammatory. Commonly drugs which we prescribe in clinic include naproxen and diclofenac. There are specific ones we use sometimes for gout. Indomethacin is one of those. Sometimes for menstrual disorders, particularly for back pain and abdominal pain associated with periods, we use mefenamic acid. And some of the newer COX-2 inhibitors and medications are celecoxib and etoricoxib. These are usually started by specialists in secondary care. Now, due to the nature of reducing prostaglandins, some of the side effects are predictable, including heartburn, stomach ulceration or gastritis, general stomach upset, diarrhea and dizziness. So due to the nature of the way they work and the effect on prostaglandins, I often do prescribe a GI protectant in the form of a capsule called lansoprazole to help reduce the risk of side effects. One of the pieces of advice I often do give patients is please be careful with these medications, and if there's any signs of bleeding from the GI tract, whether that's vomiting, coughing up blood, or bleeding from the back passage, or distorted colour of the stools, particularly dark stools, then you need to contact your healthcare provider. Now, there are some long-term effects associated with NSAIDs, and these include increased thrombosis or clotting risk, problems caused by their effect on the kidney and renal system, and occasionally they can cause problems with breathing difficulties, particularly for those patients who have associated conditions such as asthma or COPD. So I often advise patients and clinicians to remain vigilant for side effects and exacerbation of other conditions. If this is done, then these drugs can be used fairly safely. So research is ongoing with respect to efficacy of these medications in chronic pain. However, there are some trials for low back pain in particular showing that NSAIDs are more effective than placebo. And NICE, the National Institute for Health and Clinical Excellence, have recently advised that a low-dose anti-inflammatory can be useful in the management of acute low back pain. So my recommendations are as follows. Only use when the benefits outweigh the risks. As with opioids, the lowest effective dose for the shortest period of time is quite useful. Start with those medications which we have most experience of, for example ibuprofen and naproxen. These drugs have been around for many years. It's not recommended for long-term use, and there's no set time which is considered long-term. I've just put an arbitrary 6 months in there. Try and avoid alcohol, as there is increased risk of gastrointestinal bleeding. If patients are not receiving any benefit from one anti-inflammatory, it may be worth switching to another one. Always try and review the benefits against the harms. Be extremely vigilant about GI side effects, and also being vigilant with the elderly and patients with renal problems. These medications have similar effect with respect to efficacy to paracetamol, so sometimes it can be useful to use both at very low doses. So in conclusion, these medications are very often used in primary care and can be useful for acute inflammatory pain. Research is ongoing with respect to their use in chronic pain, but they are useful for specific conditions such as rheumatoid arthritis and osteoarthritis. With patients, I often advise them to use them intermittently and always have them after a meal. And it's often useful to keep a small supply at home, particularly during exacerbations or flare-ups of conditions. So would I recommend this type of medication? Well, I've decided to give it a thumbs up and a thumbs down because they are useful for acute inflammatory pain, but there's no long-term evidence that they are useful for chronic pain, and clinicians and patients need to remain vigilant with respect to side effects. So next week I will try and summarise some of the current evidence with respect to other therapies that patients are using to treat chronic pain. So once again, thank you for listening. Please subscribe to the channel, like and share far and wide, leave any feedback down below, and once again thank you for your time.